So just by way of declaration, I am actually a gastroenterologist. So you might be wondering, what the hell am I doing talking about pregnancy and so forth? But I hope to convince you by the end of this session that the gut and gut health is really relevant to so many of human health and disease. And this is why we're so excited to have established Australia's first microbiome research center here at St. George in your backyard. So we're really delighted that we're doing so much research and working with the giants of obstetrics like Greg and his colleagues to try and advance pregnancy care and particularly preconception care. So I've been asked to talk about the microbiome, gut health and pregnancy outcomes. And I'll take a liberty of also advertising one of the big studies that we're doing here at St. George, and it's a national study now called the MothersBabies Study. But first, I'd like to give you a brief kind of summary of what the microbiome is. We talk about the microbiome and the microbiota. The microbiota are all the microorganisms, the trillions of microorganisms that live in and on us. The bulk of them obviously would be in the GI tract, particularly in the colon, and also in the oral cavity, but almost every part of the body will have its own unique microbiome. The microbiome is kind of the collective genome, all the genetics, the genetic power that you find in this microbiota. So we're outnumbered, certainly in genetic power, by these microorganisms. The microbiome controls quite a big part of our metabolic output, equivalent to the liver, which is quite an astonishing kind of statistic, because the liver is this big industrial zone in the human body, and the microbiome is equivalent to that. Now, the microbiome starts to form from the moment of birth, and it stabilizes usually by the age of 3. And to cut a long story short, it's been implicated in almost every human disease and every aspect of health. So the first clinical practice learning point is that the microbiome is a new frontier of medicine and promises major advances in the near future. Now, this microbiome has been linked, as I said, to many aspects of human health. And indeed, it's linked to human health because it has an impact and influence on the immune, metabolic, and neurobehavioral traits that we have. And as you can see from this slide, there is a kind of the bidirectional flow between disease and health, and with many environmental triggers, as well as your host genetics, that can influence that kind of that flow. Now, how does the microbiome impact on host health? This is kind of a slide showing the intestinal mucosal immune system, but you could replicate this in the lungs, for example, again, the kind of epithelial layer, in vascular beds, inside the breast, in ductular epithelium, in the pancreas, almost identical kind of scenario. And this interface between the outside and the inside, and you're being protected across that epithelial barrier by your immune system. And what you try and achieve is a kind of coexistence, not too much inflammatory or immune response so that you destroy yourself, but equally you want to have a kind of a degree of tolerance, but be ready to confront any invading pathogens. That's the essence of healthy homeostatic living. Now, if for any reason this barrier is disrupted, and it could be disrupted because you've got the wrong balance of microorganisms, because you've been stressed, both physically as well as psychologically, burns, alcohol, infections, all of these things can weaken that barrier and lead to what we call translocation. So that's a translocation of the microorganisms, bacteria, for example, but also their antigens and their metabolites that can then travel from, say, the gut to distant organs. They can affect the gut-brain, the blood-brain barrier, the kidneys, the lungs, the liver. And this is why you can have impact outside of the gut. You can have an impact, for example, on your metabolism and the risk of diabetes, or your mental health, and so forth. And this is all the kind of the essence of it, is that weakened, leaky gut barrier or other epithelial barrier, and then translocation. Now, how does the microbiome actually exert such effects? I mean, it's not the bugs themselves that do this, but it turns out to be the metabolites, what they actually produce. So we're constantly delivering materials into the gut, like fiber, indigestible fiber, amino acids, phytochemicals, xenobiotic compounds, and so forth. And our microbiota then metabolize these. For example, they metabolize the fiber to produce short-chain fatty acids. These are metabolites that have a very beneficial effect. They're kind of immune tolerant. they're good feed for the colonocytes and so forth, or they produce neuroactive peptides, for example, neurotransmitters and so forth. So it doesn't matter what bugs are there. Ultimately, we're all united in biochemistry. And this is really the essence of the microbiome kind of revolution, is the fact that these metabolites that circulate can then act on host receptors and cause problems or protect you from problems. Then we have the concept of dysbiosis, and that's the loss of that balance between the good bacteria and the bad bacteria. So the pathobionts versus the symbionts and the commensals. And if you have more of these pathogens, obviously you would have inflammation. And if you have more of the good guys, you can downregulate the inflammation and protect the host. Now, the net effect is that, and this is kind of the underlying principle of all human disease, is that chronic inflammation is the root of all evil. If you have that imbalance and you have an excess of pathogens, that will really lead to the host mounting an immune response, an inflammatory response, and this low-grade inflammatory response can cause major problems for your health. Now, what factors impact on the microbiome? Well, many factors impact the microbiome. Perhaps the most important is diet, because that's what we feed on, and that's what we feed our microbiota on. So whatever we eat, whatever kind of waste products that we send down the way into the colon is actually the feed for those microbiota. So if you've been dieting and eating unhealthy, Western type diet, for example, that will lead to a very dysbiotic microbiome. And equally, if you are consuming healthy diet, fresh fruits and vegetables, nuts, legumes, and so forth, that will produce a very diverse and healthy and balanced microbiome. Other aspects that can affect the composition of the microbiome include geography, so where you live, and that's really a reflection of what soil that food is being grown in and so forth. Effect of life cycle changes. Obviously, as you grow older, there is a natural kind of change that happens with the microbiome. Stress, as I mentioned, both psychologically and physically, and medications. And we as doctors are often very guilty in not really questioning the necessity of having patients on polypharmacy or giving medications that have no indications, like the epidemic of proton pump inhibitors, for example, that almost all patients are on. These will have a profound effect on the microbiome, and then will in a negative way. So there are also obviously host variables as well as host genetics. For example, stool consistency, your bowel habit, how much alcohol you drink. All of these things can also have an impact on the composition of your microbiome. So where does the microbiome come from? Well, this is a very nice study that was published a couple of years ago, and this has tracked healthy mothers and their babies and looked at different sites in the mother. For example, the oral cavity, skin, stool, and vaginal microbiome, and then followed the babies for up to 4 months. And as you can see, essentially the baby gets most of its microbiome from the mother. And as the baby grows, there is a kind of a niche selection. So the gut-derived mother microbiome ends up in the baby's gut, the skin under the skin, and so forth. And this is a very important concept, because the mother then passes on the majority of that microbiome. And if that microbiome is dysbiotic, then we have a problem. Then you have the basics, the essential elements that can lead to problems down the line. And this is demonstrated by this nice study published 2 years ago, showing that infants born to mothers with inflammatory bowel disease present with an altered gut microbiome. So they already have a dysbiosis that they've inherited from the mother. And if you took that, that poo from the babies and put it into a mouse model, germ-free mouse model, they develop abnormalities of the adaptive immune system. So you can kind of transfer that immune abnormality. And it's now reasonably well established from some fantastic work that is appearing almost every week, that this epidemic of allergy, obesity, asthma, all of these things can actually be traced back to that dysbiosis in the gut microbiome. Now, this is another study that looked at the host remodeling of the gut microbiome and the metabolic changes during pregnancy. So this is looking at healthy pregnancy, looking at the first trimester, looking at the third trimester, and then looking at the composition of the microbiome. And the curious thing about this particular study is that obviously, they found that there was a change in the microbiome. And as the women accumulate weight, the expected weight gain in pregnancy with insulin desensitization, if you took the poo from the first trimester from the mothers and from the third trimester and put it in a mouse model, the mice that received the third trimester poo basically developed obesity and insulin desensitization. It's almost like you're preparing the mother for having this very aggressive kind of microbiome. And this may be an inherent mechanism to protect the mother from the potential of famine. So this is a kind of like perhaps an evolutionary kind of safety mechanism. The problem with this, of course, is that we're not living in hunter-gatherer times. We're living in a modern society where everything's obesogenic and things can overshoot. And perhaps this kind of dysbiosis that is supposedly protective can lead to problems down the line. Now, is there any evidence that the microbiome is dysbiotic during pregnancy? And could we predict these adverse outcomes? In other words, if you follow a pregnancy, and particularly if you start sampling at the beginning of pregnancy, can you anticipate, can you predict whether someone is going to get preeclampsia or gestational diabetes and so forth? Now, excitingly, the papers are starting to appear, and they're very, very, this is almost like sci-fi. 10 years ago, who would have thought that you could predict who's going to get preeclampsia or gestational diabetes just by analyzing a stool sample? Well, this is a study that was published last year. This came from China. And this showed that, in fact, the gut microbiome of patients that developed preeclampsia is indeed dysbiotic. And this is detected in the first trimester, kind of before the preeclampsia is developed. And if you took that stool again and you put it in a mouse model that doesn't have preeclampsia, it will develop the disease, showing that there's a direct link between that stool that comes from preeclamptics and the development of that disease kind of phenotype. And this offers hope because it is possible that the gut microbiota can be a screen to try and predict who's going to get preeclampsia and then institute kind of preventative treatment or preemptive treatment before then. And this is a very nice kind of editorial that was published in JAMA, actually commenting on that gut paper. This paper has just appeared in press, so it's not actually been fully published yet. Again, very exciting because it shows an association between the gut microbiota in early pregnancy and the risk of developing gestational diabetes. These were large numbers. These are a very, very good study. And again, it's very, very promising because it shows the microbiota during early pregnancy is associated with subsequent risk of gestational diabetes, and that several of the beneficial or commensal type microorganisms were inversely related to the incident gestational diabetes, while those opportunistic pathogens were actually more represented and higher risk for the development of gestational diabetes and correlated with glucose levels on the OGTT. Very exciting stuff. Now, there are currently no studies on the microbiome pre-pregnancy. We would argue that it's nice to predict things, if you like, during pregnancy, but even better is to prevent. And you can only prevent adverse outcomes pregnancy if you start preconception. And this is why we established here at St. George and now across the whole of Australia, this MothersBabies Study that I'll talk about towards the end if we have some time. And I call upon you to help us in terms of recruitment for this very, very important study. Now, the other thing, as GPs, you will always be bombarded. There's a lot of kind of knowledge out there amongst your constituents, your patients, about gut health and about testing for the microbiome. And they will ask you things, is it worth me testing my microbiome? Which one should I go for? What company, all that kind of stuff. All of these questions are being asked all the time. I certainly get asked this in my clinic. So how do we actually investigate the microbiome? And is this personal microbiome testing of any use? Well, this is where sometimes, the commercial aspect of science way outstrips the pace of the actual scientific developments. And it's much to my annoyance that this happens because it's not usually based on very solid foundations, and it's jumped the gun, as it were, and then obviously being commercialized. And you've got lots of different companies that are projecting these as the way forward in terms of understanding your health and living happily ever after and so forth. The problem is that there are lots of gaps in knowledge, and we cannot really rely on these as diagnostic tests. This is curiosity kind of side of things. That's not to say that in the future, once we refine our approach, once we actually provide the evidence base, that these will become very important constituents of the doctors and the healthcare providers' armamentarium against disease, particularly in terms of prevention. So there's a plethora of these things across the globe, including here in Australia. Some of them are better than others. Some of them use different types of technology, and this is very important to understand because there are different ways of looking at the gut microbiome. For example, if you're using the simple kind of genetic signature, which is conserved, for example, across bacteria, this is what we call 16S ribosomal RNA signature. This is a conserved sequence. Essentially, it's just telling you who's there, what bugs are there, but it doesn't tell you what they do. If you do a more sophisticated approach like metagenomics, it doesn't just tell you who's there, but it tells you what can they do potentially, what these genes can potentially do, but it doesn't tell you what genes are actually actively working and being transcribed. And this is kind of the most advanced one, is this meta-transcriptomics, which tells you who's there, whether they're alive or not, and what they're actually doing. The problem is, of course, is that this is very expensive, time-consuming, and obviously not very practical at this current time. And then they provide you with this microbiome report. And many a time I would see patients at my clinic coming to see me and saying, I've got this report, what the hell does it mean? And I look at it and I think, well, what the hell does it mean? Exactly. I mean, there are so many kind of missing gaps in that, in interpretation of that. And part of the problem is that most of these commercially available tests rely on so-called a healthy control group. That's not a healthy control group. It's the rest of the population who have labeled themselves as being healthy. So when they fill out that questionnaire and say, do you have this, and that? And they say, no, no, no. I mean, that's then regarded as a kind of reasonably healthy person, but it's not really optimal health. So that's a big, big gap that we are assuming that if you don't have a particular disease, that you're actually a healthy person. And that means it's a healthy microbiome. The other thing, of course, is that the definition of healthy is the most difficult question in the microbiome. We don't know what it is because we've always come to it from the end of the microbiota. In other words, what bugs are actually beneficial, what bugs are harmful. And this is not a straightforward question. This is a very difficult question because you've got sometimes the kind of a dual function of these bugs. In a particular context, it can be healthy, but in others, they might be harmful. So this is another kind of complexity that we, as the researchers and the scientists, have to define and sort out before we can kind of roll this out. Now, and this is why this is another study that we're doing here at St. George. And again, it's the first in Australia. And this is looking at defining the so-called healthy optimal Australian microbiome. Now, for this one, we're not starting from the end of the microbiome. We're starting from the health of the phenotype. Who is the healthiest person that we would like to be, to emulate? And from that point of view, I was asked that question a few years ago, who would you like to get a fecal microbiome transplantation from? And I thought, an Olympic athlete, that's, somebody who's so fit and healthy, they eat well, they exercise, and so forth. So this particular study that we've set up here is looking at the athletes, but not kind of Olympic standard, but who are physically and emotionally and mentally fit. We're also looking at people who are centenarians. Those are the people that survived all of the slings and arrows of outrageous fortune and made it to that advanced age and retained full mental function, so they have no dementia, as well as the active adolescents. So once we have that signature and define it for the rest of Australia, I think we would have a very robust signature that we can call a healthy microbiome. So in conclusion about these commercial microbiomes, lots of limitations, much still unknown. You need the large targeted cohorts, comprehensive metadata, and then prospective clinical trials. And this should really be the function of governments, the function of healthcare providers, and this should be part of our clinical practice to actually test these in clinical trials and then make some real progress. Now, can we actually manipulate the microbiome to impact on health? Now, this is the most exciting aspect of the microbiome, is that unlike our genes, which we're stuck with, we can't change our genetic makeup, you can very easily manipulate and change your microbiome. And this is really the essence of prevention of human disease. And this is why I think it's worth all the investment, all the cost, all the effort to go into understanding this microbiome. So there are so many different ways you can do it. And I've listed the classic ones. Diet, as I said, is the most important. Exercise, the concept of prebiotics, probiotics, symbiotics, we kind of lump them together. Postbiotics is essentially delivering those metabolites that are produced by the probiotics, and antibiotics in certain contexts can then get rid of some bad bugs and give you some relief. And finally, fecal microbiota transplantation. I'll just give you examples of what's already been published, some of the key studies. Now, this is one study that was published. In fact, it's just appeared in print. And this is looking at your diet. So this looked at a large number of individuals and looked at what kind of diet they have whether it's a Western type diet, whether it's a healthy diet that is enriched in plant-based foods, which are linked to a healthy microbiome and the production of short-chain fatty acids. And it turns out very nicely, very clearly demonstrated that what you eat determines what your bugs are like, what your microbiome is like. So if you're on a bad diet, you've got a bad microbiome, you've got dysbiosis. If you're on a healthy diet, you've got the exact opposite. That's the kind of a good ingredient for health. Now, this was a very exciting study. It made headlines when it was published just a few weeks ago in the New England Journal of Medicine. And this was in the context of malnourishment in third world country. And this looked at infants between 12 and 18 months old. And this was giving them a supplement that was basically a microbiota directed food intervention. So this was a designed kind of supplement, if you like, that will beneficially affect your microbiome, lead to enrichment of some of those probiotic type microbiota. And it showed very nicely that you can impact on the growth and development of these babies and these infants. So this is very exciting stuff. So you can overcome the risks and disasters of malnutrition with just a simple supplement. Very promising early work, but hopefully this will be expanded. This is another study, and these are clinical trials. So this is actual, proper data, looking at the Mediterranean diet and how that, given over a year, the so-called New Age study. And this was a one-year intervention across 5 European countries and looking at frailty. So this is older people, and showed very nicely that if if you're on the Mediterranean diet, you upgrade your microbiome to a much healthier, more diverse microbiome, and that correlates with clinical improvement in frailty and other parameters. Exciting stuff. Now, look at this picture. And this is something that actually, I love this picture because it shows you how wonderful nature is. And, when we talk about the healthiest diet, it's all about fresh fruits and vegetables, plant-based foods, not necessarily a vegan or a vegetarian diet, but one that is, enriched in these plants. And the magic figure of all these different types of plants is 30 per week. It's not difficult to actually fulfill that, within your average week. And it's great fun to actually go out sourcing that kind of diet and these ingredients. And the greater the color variation, the higher the impact, and the better it is actually in terms of diversity on your microbiome. Seafoods, olive oil, the ingredients of your Mediterranean diet all feature in this beautiful picture. Now, what about the the current situation in Australia? This is a study that, again, just published this year. I think it's from Western Australia. And this looked at the fiber intake in pregnant women in Australia and showed that, in fact, only a third of pregnant women, 30% of pregnant women only, are actually hitting the adequate intake target of dietary fiber of 28 grams per day. And so this is very illuminating because it tells us there is hope. There is some scope for us actually improving preemptively health of prospective mothers by improving the diet, supplementing the diet with fiber and so forth. Again, very nice work. Physical activity. Almost every condition that known to humanity will be improved by physical activity, particularly cancer, diabetes, metabolic disorders, and so forth. So exercise and physical activity. It doesn't have to be running marathons, but it's just some physical activity. And I think that's the other advice that you could give to your patients. So diet, exercise, very important contributors to health. What about probiotics? Now, you will be asked ad nauseum about whether probiotics are useful or not. The concept of probiotics is obviously valid. However, the products that we have are not necessarily the right ones, are not necessarily the ones that we should be taking. It sounds like a good idea, but in fact, these have, by and large, have not been actually subjected to rigorous clinical trials. Those that have usually failed that kind of very rigorous measure. And again, to cut a long story short, I've just provided you with this Cochrane kind of library. This is a database systematic review, and this is looking at probiotics in relation to preventing gestational diabetes. So this is, as relevant to pregnancy. There is low certainty evidence from 6 of those trials that they managed to look at that there's any relationship between probiotics and risk of GDM, either positive or negative. So it doesn't protect you from gestational diabetes. On the other hand, there is high certainty evidence suggesting that there is an increased risk of preeclampsia with probiotic administration. Relative risk of 1.85 with confidence intervals that don't span unity. So this is very interesting stuff. A lot of work needs to be done, for confirming this. So cut a long story short, probiotics are not necessarily the answer. However, don't despair, because I think if we use the next generation probiotics, there may be some benefit. And this is one of those next generation microbiota called Akkermansia mucinifera. Some of you will have heard about this. There are already clinical trials with this. This was published in Nature Medicine a couple of years ago, showing that if you take it either as heat inactivated or as the live bacteria, it can actually improve your metabolic parameters and in terms of your insulin sensitivity and blood sugar and so forth. So, promising stuff, not definitive. Finally, fecal microbiota transplantation, and this is something that is very topical. It works for C. diff. It might work for some kind of inflammatory conditions like inflammatory bowel disease, but it's a long way from what we need to be doing. And there are advocates of this, but I think there's just still a lot of stuff to be sorted out, and it's not particularly palatable. We really need to kind of purify that before we can give it properly. Now, finally, in the last minute or two, I'd just like to advertise this study, the MothersBabies Study. This is a world first examining the microbiome and observing the changes before pregnancy, where this is the most difficult study to conduct because we're recruiting pre-conception. These are prospective mothers who are actively trying to conceive, and we would like to recruit them. Some questionnaires about the diet and so forth, as well as some microbiome samples, oral, vaginal, stool samples, skin samples, and so forth. And we take these until they fall pregnant, and then at the trimesters 1, 2, and 3, and then up to a year postpartum. And we also look at I'll just skip down in the interest of time, and also invite their partners to contribute also a microbiome sample at the outset. So we would have the whole thing, as well as the babies. So we also follow the babies for up to a year. Now, that cohort of babies will obviously become a very valuable treasure for the health of Australia, because we can follow them up, until adulthood and find out exactly what contributes to their microbiome and to their health. And the collections are very simple, very easy, self-collected. It could be done virtually, and they send their samples by post. It's really quite easy. As I said, we also collect the samples from the babies. I hope that I'll be able to give you a QR code at some point and some literature so that you can help us out in terms of recruitment. We'll be immensely grateful to you. Now, future medicine is going to be precision medicine and individualized, personalized medicine. And this is where artificial intelligence is going to be very, very important. And this is the final take-home message, is that welcome to the era of personalized medicine and artificial intelligence. And I think the microbiome, this omic, is going to be very, very beneficial to health and disease in the world. This is just a picture of my wonderful team at the Microbiome Research Center. And I would like to thank you once more for your attending tonight and for listening to my talk. Thank you very much.
Can I ask a question?
Yes, please.
So it's Deb Kennedy. I was just wondering, do you exclude women who are on long-term medications and women with things like inflammatory bowel disease from your study?
Absolutely none. Everybody's welcome, and that's part of the kind of the question that we're trying to answer is, so if, for example, if you've been taking medications or have a medical condition, your microbiome at the time of conception is very, very important. So it doesn't matter what you've done to get to that point. We want to know what it was just before you fell pregnant. So everybody's welcome. It doesn't matter whether it's a first baby or 10th baby. Any complications, we welcome everybody into the study, because we want a collection of essentially samples that come from healthy pregnancies to act as the controls, as well obviously complicated ones, with like gestational diabetes, preterm labor, and so forth. So that's it, and we're aiming to recruit 2,000 women. So that's why it's a big study and requires everybody working together. And I'd love it if our own backyard here, obviously, in our catchment area, could contribute the biggest number to the study. So far, we've recruited 200 women. Obviously, COVID was a particularly bad thing for us because you couldn't do any kind of clinical research, but we're hoping to ramp up and reach that target, hopefully within the next couple of years.
We have one question. Somebody asked if, do we Google the study to get patients to enroll?
There is a website, but I'll also send you some flyers, and hopefully Lauren will pass this on. There's a flyer that we actually use in our advertising and promotion, and it will have a QR code that if the participants can, they can then get into the questionnaire to establish eligibility. The main thing is that we're not recruiting pregnant women. So this is sometimes that's the kind of the biggest confusion. We want to start preconception, but women who are actually, seriously thinking about becoming pregnant.
There's another question. I thought there was a recommendation for a particular strain of probiotics in the 3rd trimester to reduce atopy in children. Is there a weak evidence for this to your knowledge or disproved?
Yes, so there is weak evidence, but unfortunately it's weak evidence both ways. And in all honesty, most of these studies will be very underpowered. Any study that has been adequately powered, to answer that question has found no benefit. I would love it to work. Don't get me wrong. I'd be delighted if there's something that we can give, like a probiotic or a probiotic-prebiotic combination that works. But let's just find out what it is and just give the right stuff instead of just having a mixture of random, bifidobacteria, lactobacilli, and so forth without actually any proper clinical evidence. So, but this is coming. As I said, don't despair. But I just, I would like to see that evidence base very robust before I would give it to pregnant women.
That's all the questions at the moment.
Great. Thank you very much.
Oh, sorry, no, one more. What are the main risks of probiotics aside from preeclampsia?
There are no main risks. It's just that there are no main benefits. That's the biggest problem. They're very expensive, and I just think it's a wasted opportunity. I think it just, because as always, these have been developed very quickly because the concept is valid, but you can probably get all the the good probiotics from natural products. They enrich your own microbiome, for example, by providing the infrastructure, by providing the prebiotics, which is what you get from the plants. That's your prebiotics. And then hopefully with your other activities like physical activity and so forth, you will develop your own probiotics, which will obviously be specific to you and beneficial to you. I think this is a far more rewarding approach than just popping a tablet of a random mixture of probiotics.
Another question around that earlier in the presentation you mentioned leaky gut. Is this different to leaky gut syndrome, which is often diagnosed by naturopaths, etc., and which I understand has little evidence?
Yes, so a very intelligent. This is very, very important question. So everybody talks about leaky gut. It's a concept. To actually diagnose leaky gut is a very unrewarding, difficult thing to do, but it is possible to do it in a research context. But there are certain things that can be administered and then measured in the blood that show that there has been a translocation, so it's the same thing that we talk about, that the naturopaths talk about, but this is a concept that is, the one that I was talking about is one based on clinical studies and preclinical studies that have shown actual leaky gut and translocation. In other words, it's been proven, but it doesn't take much to disrupt that barrier. I think it's whether you have a diagnostic test, a clinically diagnostic test that can show that leaky gut is a lot more difficult.
Thanks very much, Lauren, and thank you for the opportunity to speak. Looking at my slides, I felt compared to Emad's, they look rather dull and boring. However, I do apologise in advance. This is a rather dry sort of topic, but I promise to only keep you for 20 minutes. And I do have a very important message that I was wanting to transmit to everybody. Which I would like to. So what is the problem? Hypertensive disorders in pregnancy affect 5 to 10% of pregnant women. Cardiovascular disease is the leading cause of death in women globally. And compared to women who are normotensive in pregnancy, women that have a hypertensive disorder in pregnancy have a 3 to 4-fold risk of chronic hypertension in the next 15 years and a 2-fold increased risk in cardiovascular disease and death. So why is that? So the significant physiological demands of pregnancy have long been recognized to be a stress test that either unmasks a predisposition to cardiovascular disease or initiates a cascade of vascular changes leading to cardiovascular disease. And there are a number of differences in the pathophysiology of preeclampsia, early versus late preeclampsia, which reflect these as well. But I think it's really only in the last 10 to 15 years that there's the things that we were taught as medical students is that preeclampsia disappears after pregnancy, or at least by 3 months, but it doesn't necessarily go away. And given that about 30,000 Australian women each year will have a hypertensive disorder of pregnancy, this is a very significant issue. Unfortunately, I feel the Americans have been significantly ahead of us in this, and this is a statement issued by the American Heart Association early last month, looking at adverse pregnancy outcomes and cardiovascular disease risk. And what they defined as adverse pregnancy outcomes were, first of all, it affected 10 to 15% of pregnancies. And this is probably an undercall, really. It's probably even more than that. And so preeclampsia affects 2 to 8% of pregnant women. Gestational hypertension affects 2 to 3%. Gestational diabetes affects 2 to 10%. Preterm delivery, 10%. Fetal growth restriction, 5 to 15%. Small for gestational age, 10%. And abruption, 1%. And those are what they define as the adverse pregnancy outcomes. And of course, a lot of women will have a combination of those factors. So a woman with preeclampsia may also have, or has an increased chance of having gestational diabetes. She's more likely to be delivered early because we do that. The baby's more likely to have fetal growth restriction, and she may end up with an abruption. And just a point from that slide that to just kind of go off a little on a tangent, the difference between fetal growth restriction and small for gestational age is that a fetal growth restriction, the baby doesn't reach its genetic potential in terms of growth because of a placental function problem. And small for gestational age just means it's less than the 10th centile. So that includes babies that are growth restricted and those that just genetically were going to be smaller than expected. Sometimes you do have little people. And this is a diagrammatic form of what I've just been saying that we had in a recent article that we published. So in the center, you have the pregnant woman, and around the circle around her, we have hypertensive disorders, gestational diabetes, preterm delivery, the small for gestational age baby, and then the current exposure to pregnancy risk factors. So if a woman has more than one pregnancy where she has preeclampsia, then her subsequent risk of hypertensive disease actually increases. And around the outer circle, we have coronary artery disease, stroke, chronic hypertension, both of which I've mentioned, but interestingly also end-stage renal disease. So the women that have had preeclampsia have a 5-fold risk of later developing end-stage renal failure. To go back to the American Heart Association, so these association with mortality and cardiovascular disease outcomes. So along the top of the table, it has pregnancy outcome and what it's associated with, and then the strength of the evidence. So, excuse me, what they've labeled as A is if there are good cohort studies and consistent meta-analyses of the studies, it's considered A. B is where the evidence is not as strong. Down the left-hand side, you have the hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, small for gestational age, large for gestational age, abruption, miscarriages and stillbirths. And you'll see all of them are associated with what they call atherosclerotic cardiovascular disease. But what I would like to concentrate on tonight is the hypertensive disorders. I mean, I think all of us realize that just gestational diabetes is associated long-term with an increased risk of type 2 diabetes, but perhaps not as much about its increased risk of cardiovascular disease as well. The other reason that I want to focus on the hypertensive disorders is that's where we've been doing work at St. George for a number of years now. And it all started with this P4 study. So this P4 stands for Postpartum Physiology, Psychiatric and Pediatric Study. And I think this study was cooked up by Professor Mark Brown and myself on a plane back from a hypertensive meeting in Japan. And the real reason was that no one actually knows what normal blood pressure is postpartum. We all use 140/90, but these are young, fit, healthy women. And what is normal blood pressure? And secondly, do women who have had preeclampsia have higher blood pressure postpartum? There is some evidence that they do, but the evidence is pretty sketchy. So we started recruiting in June 2013 and recruited 302 women who had a normotensive pregnancy and 90 with preeclampsia. And we followed them up at 6 months, 2 and 5 years postpartum. Now all have completed their 6-month and 2-year follow-ups, and we're currently analysing the 2-year data. And there are 141 to complete their 5-year assessments, and which will finish in December 2023. And these are some of the results. So this is the booking visit with their GP. And so along the top, we have the two groups, the normotensive and the preeclampsia. Down the side, we have BMI, their systolic blood pressure and diastolic blood pressure. And what you can see is that the preeclamptic woman, even at their booking visit, they have a higher BMI and higher systolic and diastolic blood pressure. So it actually starts, the woman destined to develop hypertension start with a higher blood pressure and BMI, but it's within the normal range. And this has been in our paper about this. The main result, the blood pressure at 6 months postpartum, was that the upper limits of normal blood pressure, and we defined this in the normal group as the mean plus 2 standard deviations. So was 122/79, which is an impossible number to remember. So we have adopted the 120/80 as a much more sensible, practical number for you to remember. And using this new definition, so in the table below, if we look at with the woman with preeclampsia in their pregnancy, along the top we have the old measurement, which is, as we all know, 140/90, and then the second one, 122/79, and we have systolic blood pressure and diastolic blood pressure. So using the old measurement of 140/90, none of the women at 6 months had a systolic hypertension, and only 3% had diastolic hypertension. But using the new figures, 13% had systolic hypertension and nearly 19% had diastolic hypertension. So this means 19% of women with a history of preeclampsia will have an abnormal blood pressure at 6 months postpartum. Now, we don't know, we don't have the data yet to know whether this is the target group that we should be focusing on, but common sense would suggest that these are the more women who are most likely to get cardiovascular disease, but we're really looking at a surrogate marker of it, not at long-term outcomes. The other differences that we noted at 6 months, and again, it's a similar slide, normotensive, preeclamptics, BMI down the side, HDL, triglycerides, and HOMA score. So you'll see that these women at 6 months, again, were heavier. They were still heavier. Their HDLs were lower, their triglycerides were up, and they were more likely to have, then they had a higher HOMA score as well, which are all features, as I'm sure you are all very much aware of the metabolic syndrome. Looking at the 2-year data, as I've said, that we've only just started looking at these figures, and 11% of the women with a normotensive pregnancy had an elevated blood pressure over the 122/79. And we've explained this by purely on the basis of statistics. First of all, you'd expect that 2% or just over 2% of women would have a blood pressure over the 2 standard deviations. And we presume the other 9%, it's just related to age changes, because we looked at BMI and that hasn't changed since 6 months. But I think the really interesting figure is that nearly 1/3 of women who had a preeclamptic pregnancy had an elevated blood pressure above the 122/79. So whatever we're doing as medical practitioners is not really working. So what should we be doing with these women? We're not sure. They're all the usual things that people talk about: lifestyle modification, weight loss, control blood pressure, reduce lipids, and check glucose control. But what works for these things? I'm sure as GPs, I have many, many frustrating patients that you try to change all these lifestyle factors without success. And there's very little evidence of what works in these patients. There isn't any real evidence, sorry. And because of this, that led us on to a new study that we are currently involved in, and this was funded by New South Wales Health, which is important, as I'll tell you later on in the slide. So we're recruiting 500 women who had preeclampsia in their pregnancy at 6 months postpartum. And this is a randomized trial. So it's a multi-centre trial here in Sydney. So St George, the Royal Hospital for Women, Liverpool, Campbelltown, Westmead are all involved in this study. So women are either randomized to what we call optimized usual care. So they're given an information package about the importance of hypertension in pregnancy, and they're asked to see their GP at 6 months postpartum. The second arm is a brief intervention arm. So they're given an information package, plus they're seen and talked about lifestyle behavior change at a specialized clinic with an obstetric physician and a dietitian. And then the third arm is what we call the extended intervention. So it's the same as the second group, plus they're enrolled in a 6-month telephone-based LBC program from 6 to 12 months postpartum. And this is the New South Wales Health Get Healthy program, which they strongly suggested that in order to get the funding, we should involve the Get Healthy in this. So the women are assessed at 12 months, and the primary outcomes are a decreased blood pressure and increased weight loss in group 2 and group 3. But we really don't know at this stage whether any of these things will make any difference. So how do we suggest that you actually follow up women who have had preeclampsia? So this is this is not based on any evidence. It's what we would consider to be expert opinion, which is, as you all know, the lowest level of evidence. So at 6 weeks postpartum, they should be seeing their GP or their obstetrician if they've had an obstetrician, and making sure that they're taking their blood pressure. Then importantly, at 3 to 6 months, either their GP, or if you have access to a multidisciplinary team, so an obstetric physician, dietitian, etc., their blood pressure, and preferably, if you have access to it, a 24-hour monitor or home blood pressure monitoring. A metabolic screen, BMI, fasting glucose and lipids, and dipstick for albuminuria and proteinuria. So referring to a renal physician if there are signs suggestive of secondary hypertension or of persistent albuminuria, and refer to a cardiologist if there's established cardiovascular disease. And then their ongoing care, once again, comes back to their GP with yearly weight and blood pressure, and every other year glucose and cholesterol. So just to summarize, adverse pregnancy outcomes affect at least 10 to 15% of pregnancies. All are associated with an increased risk of later cardiovascular disease. And that's really what the essence of my message tonight is. Women who develop preeclampsia are more likely to have high blood pressure at their booking visit. So you should consider starting them on low-dose aspirin and calcium. There's a new upper limit for normal and for blood pressure postpartum, which is 120/80, and that's my second message. We need to focus on the abnormal ones postpartum to hopefully, and I'm not sure that we are going to be able to, reduce their long-term risk. And we don't know what appropriate follow-up should be, but being aware of their increased risk in terms of GPs and educating the woman, we think is a very good start. I have a list of references there that I have referred to in this talk. And I'd like to thank the PHN for giving me the opportunity to talk to you, and hope that you can spread that message to your peers as well. Thank you.
Thank you so much for your presentation. There's a couple of questions in the chat. The first was at the beginning of your presentation, so you might have covered this, but it says, isn't preeclampsia a different pathophysiology to hypertension in pregnancy?
Look, I think that's an excellent question, and you're exactly right, Jane. I think hypertension in pregnancy, gestational hypertension, is different to preeclampsia, but preeclampsia is not a single pathophysiology as well. So early onset preeclampsia prior to 34 weeks is associated with all those pictures that you learned in medical school of the placenta not the arterioles not invading the placenta and placental not forming properly. But late onset preeclampsia doesn't have those pathophysiological changes. So the whole lot is very confusing, I think. And certainly in terms of the long-term effects, gestational hypertension is also associated with an increased long-term cardiovascular risk. So it's not the benign condition that we've always considered it to be.
The next question is, at the initial visit for a pregnancy, say at 5 weeks, if you check blood pressure, it is high, do you suggest we start medication immediately? Or should we check blood pressure across a few more days episodes before acting in case it's an aberrant reading?
Again, that's another good question. I certainly don't think a one-off blood pressure, unless it is very high, and if it's 160/100, then obviously they need to be seen urgently and dealt with urgently. If it's up around the 140/90 or 140/100, you're probably better. You would normally expect that her blood pressure is going to fall in the second trimester anyway with a normal pregnancy, and she's not at risk of an acute complication of hypertension. So I would generally hang off treating that early. And I think the thing to do is to actually refer her to antenatal clinic for an early appointment so we can get onto it. And what we would normally do if someone presents prior to 20 weeks with hypertension is actually arrange for them to have a 24-hour monitor to truly diagnose whether they've got pre-existing hypertension, which is what you're suggesting that they've got. So that's what we would do at St. George, is actually do that and get that done.
So the next question, what can we do prenatally if their blood pressure is 120/80 and family history of hypertension?
Yeah, again, a good question. I think all you can do really is start them on the lifestyle behavioral changes and be warning them that this is going to be a potential problem in pregnancy and setting them up for long-term management. I don't think there's anything else that you would do. I certainly wouldn't be treating them with antihypertensives.
Another question, NTU scan predicts risk of preeclampsia. If there is risk, do we start aspirin and calcium?
The people that are doing the NTS are making a fortune out of these bloods, because although they don't charge the patients, they charge Medicare. They certainly bulk bill them to Medicare, and so they make a fortune out of them. Do you start it based on that? Look, there's huge debate going on around the world in the hypertensive and pregnancy space, whether you should be treating these with aspirin and calcium. I personally wouldn't, treat it just based on an increased risk, unless there were other major risk factors, like it was an IVF pregnancy, the woman was over the age of 40, it was twins. We know that aspirin and calcium are very safe. So if the woman's really worried and anxious about it, then that's a sensible thing to do. And I think the easiest way to give the aspirin and calcium is aspirin, it's supposed to be 150 milligrams. So soluble aspirin is 300 milligrams, so half one of those, and 1.2 grams of calcium as well.
And another question about whether the revised protocol is advertised to all antenatal departments.
Well, it's kind of like we have to get this information out there. It's like we introduced the urine dipstick testing for proteinuria, and I think that was published about 20 years ago, and it's just in the last 3 or 4 years made that into the international hypertension protocol. So Jane, it's not going to happen anytime soon, and so this partly why I'm talking tonight is to try and publicize these new findings and just raise awareness for this long-term health problem that we've been ignoring, I think. And I think it's mainly come from obstetricians that we have always, once the pregnancy's over, the woman's fine and we dismiss it.
Should all patients have a urine analysis every visit, not done as often?
We don't at the public hospital. So if they're coming to our high risk clinic, then yes, they get a urine analysis each time. But we did a study probably 10 or 12 years ago, which was called the HULA study, which stood for Habitual Urinalysis as a Laborious Activity. And how pregnant women pass urine into those little yellow jars, I do not know. That's technically challenging. So I think my approach to it is, if they have normal blood pressure in pregnancy, then we don't test it, because effectively, unless they're hypertensive, you're not going to do anything based on purely on a urinalysis alone. So sometimes they will have normal blood pressure and they will have proteinuria, mild proteinuria, and we will certainly treat those women as being at risk. But again, you're not going to take any action until you've checked the blood pressure.
That might be it for the questions, Lauren.
Can everyone hear me? Hopefully. So thank you for asking me this evening, and hopefully you will stay awake.
Hi Deborah, sorry, it's Lauren.
Yeah, can you not hear me?
I know we can hear you. Are you able to pop your camera on?
Oh, you want to see me as well? Ah, yeah, okay.
That's okay, thank you.
Sure. Perfect. Okay. Is that better? Oh,
Great,
somehow
thank you.
I've somehow got the wrong camera here, but yeah. All right, that's fine.
Thank you.
So, so hi everyone. Yeah, so hopefully everyone will stay awake. So, again, like the first speaker, I'm not actually an obstetrician. I'm married to one, if that counts. And MotherSafe, just as a background, we're celebrating our 21st birthday next month, so that's quite exciting. So, I'm just going to my talk, really just the outline. I'm going to just talk some basic principles, because obviously I can't talk about every single medicine in pregnancy, but hopefully you'll get a bit of an idea about kind of a, I suppose, an approach. Again, just to talk a little bit about the pregnancy categories and why there are some limitations.
Hi, Deborah. Sorry, it's Lauren again.
Yeah.
Are you able to just pop the slides into presentation mode? Sorry, just so that they can see the whole. Thank you.
Yeah. Is that yes? Oh my God. Is that happening now? Is that happening now or not?
Yeah, are you able to? Yeah, we should just be able to see from there. That should be fine.
Yeah, is that all right? Sorry, I just somehow it just went back to my other computer. Of course, sort of. Anyway, all right. And then I'm just going to talk about some conditions. So, can everyone hear and see me now? Yes, good. So, and then some common conditions and just some more general pregnancy, some counselling issues. So, I suppose this sums it up, that people are concerned about wanting perfect babies and also want as much information as they can about exposures. So over half of pregnancies aren't planned, and we know that at least 80% of women take at least one medication during pregnancy. So typically that's between 1 and 3. So there's going to be an overlap there of a lot of inadvertent exposures occurring early in pregnancy. We also know that about 1 in 8 recognised pregnancies end in a miscarriage, and the baseline risk for any couple of having a baby with a major birth defect is about 3%, which is as high as 5 if you include neurodevelopmental problems that may not be manifest at birth. We're all aware that women are getting older, particularly in the eastern suburbs of Sydney. So there's a higher chance of having a baby with a major chromosome problem. And as Greg spoke yesterday, before, there's also a higher chance of having an underlying maternal illnesses and women possibly needing chronic medications. So this is my sort of confronting slide, but these babies were exposed to thalidomide, and I think that certainly coloured our perceptions on concerns about exposures in pregnancy. Women are worried about taking medicines and possibly put themselves at risk by stopping medicines, and equally doctors, I think, have some medico-legal concerns about women who've been exposed to medications and that they might be sued if there's a bad outcome. And there is and in the wake of thalidomide, ADEC, so the Australian Drug Evaluation Committee, was set up by TGA to really evaluate and to do the categories in pregnancy. So just by definition, a teratogen is something that's introduced in pregnancy that will increase the incidence of a malformation. So things like neural tube defects or structural birth defects. Behavioural teratogens interfere with development, so that they're things like visual and hearing problems. So alcohol is probably the best example of a behavioural teratogen. There are relatively few teratogens proven, and most are associated with a pattern of minor malformations rather than a single malformation. Picture of this baby, this child was actually exposed to Roaccutane, and that remains probably one of the worst teratogens on the market. And unfortunately, at MotherSafe this year, we've seen at least 6 women who've been exposed to isotretinoin in early pregnancy. So unfortunately, you know, they're still happening. So teratogens may not just be medications, they can be infections, maternal illnesses, hypoxia, but this talk really will concentrate on prescribed and over-the-counter medications. And these are just some examples, and the ones on the right are not necessarily prescribed medications, and the ones on the left are the medications. So just from a clinical point of view, and I think it's really important from a sort of your perspective when you're counselling patients, is around the timing of exposure. So we know that exposure to gametes, so with people who've had either chemotherapy or radiotherapy, may be infertile, but of those people who actually regain their fertility, they don't appear to have an increased risk of either having a baby with a birth defect or a chromosome problem. So that's actually very reassuring. The blastocyst, so it's what we call the all or nothing period. So that's that period from the time of conception, so day 14 to day 28, where women may not realise that they're pregnant. Again, we're very reassuring in the sense that the conceptus is really just a mass of dividing stem cells, hasn't differentiated into organs. So we'd be quite reassuring generally about exposures in that period. And the vast majority of pregnancies will miscarry. If they do, because not of an exposure, but because of an intrinsic chromosomal abnormality. So the embryonic period is really the critical period. That's when the organs develop, and that's when exposures are going to have a potential effect. And again, this you probably remember with horror from your days of doing embryology at university, but there are critical periods in terms of when exposures are going to cause a problem. And really, beyond about 8 weeks, apart from the genitalia, the main thing that all the other organs have formed, but the thing that continues to grow and develop is the brain and the nervous system. Dose response, people worry a bit about doses and try and minimize doses in terms of potentially reducing teratogenic effect. Every teratogen is going to have a no effect level in the sense that, you know, if it's a low enough, piddly enough dose, it's not going to have an effect. But we know that, and a true teratogen only is, by definition, is a drug that's going to cause a problem when there's an effect without maternal toxicity. With most medications, assuming they're in the normal dosing range, there doesn't appear to be a particular dose response, but there are a couple of exceptions which I've listed there. So valproate, over 1,000 milligrams appears to increase the risk significantly. Lamotrigine, that probably should be 300 milligrams, not 200. That's like a typo. Warfarin over 5 milligrams, and fluconazole, so high dose intravenous versus a single stat dose. And I'll talk about that in a little bit more detail later on. So the fetal period, so after 9 weeks, the fetus is formed in the sense that organs, you can't cause a neural tube defect to happen if it hasn't already, because the neural tube will have closed by 6 weeks. But there are some certain deformations or accidents that can occur when you've got an exposure. So oligohydramnios, meaning not enough fluid around the baby, can be caused by non-steroidals and ACE inhibitors. And so therefore we're quite cautious about exposures to those agents after 14 weeks, but relatively more reassuring in terms of not increasing birth defects per se in the first, in the embryonic period or the first trimester. And again, things like hypotension, cardiac arrhythmias, hypoxia, so caused by things like cocaine, antiarrhythmics, cause secondary effects in terms of vascular supply. And this is just showing sort of Potter sequence when there's not enough fluid around the baby and just causing contractures. And this is a picture of actually of a baby from Brazil, where the mother was given misoprostol to induce abortion. And you can see that there are finger abnormalities and the baby's got a squint, and Mebius syndrome, so sort of paralysis of the facial nerves. And that's due to a vascular insult early in sort of early pregnancy rather than specifically a teratogenic effect per se. So you're all aware of the categories, A to X. Those of you who know me also know my opinions on them. So they're kind of a concern in the sense that they're not black and white. And unfortunately, when people try and prescribe, or when they look at product information, that's going to be one of the first pieces of information that comes up. And certainly on your computers and on your prescribing programs, that's the produced by the drug companies. So there's a sort of strong medico-legal perspective, and they're generally with valproate and paroxetine are both category D, but paroxetine we'd be much more concerned about valproate than paroxetine. The other problem is they don't take the stage of pregnancy into account. So, you know, a drug might be not particular. So tetracyclines being a good example where they're not a particular concern actually in the first trimester, but they're actually category D. And the simple categories don't differentiate between different situations in terms of someone planning a pregnancy where you'd be much more comfortable with saying get off it versus once someone's pregnant, you might be a little more sort of reassuring. And again, is something really needed or not? They're assigned on animal studies, they're not updated, as I said, and they're really importantly at the bottom, and they're not necessarily, I think it means people don't necessarily think about, well, why is that? People don't necessarily look at the original studies, they just look at the number or the letter. And the other really important thing, which I think is a little bit confusing, is that they've got nothing to do with breastfeeding. They're really only about pregnancy. So I'm just going to get on to infection because it's such a common thing in pregnancy, and just really just talk about a few common sort of themes. And we know that some pregnant women may be more prone to infections than others, and that's possibly due to certain changes in the immune system and pathophysiological changes. And some of these infections certainly affect women more, so influenza, pneumococcal pneumonia, malaria, hepatitis E, herpes simplex, listeria, and, you know, and there's, I suppose, some mounting evidence around COVID as well. So we know that women with infection, you're more likely to get, there may be some uteroplacental blood flow issues and an increased risk of adverse pregnancy outcomes, including with significant maternal infection, including things like miscarriage, stillbirth, intrauterine growth restriction, prematurity, and maternal morbidity or mortality. The risks to the fetus are obviously congenital anomalies, neurodevelopmental sequelae, and probably the good example of that is CMV, chronic infection, which says something like toxoplasmosis, and obviously fetal death. So important in pregnancy is to investigate appropriately. So women shouldn't be denied appropriate investigations just because they're pregnant. X-rays can be performed, and in general, a diagnostic radiation, even a pelvic CT scan, is not going to result in radiation levels that are going to be dangerous for the embryo or fetus. So if you're worried, you can get an accurate fetal dose estimation, but it's really important that the source of an infection or is appropriately identified. And women need to be treated effectively because the underlying disease may well be of more clinical concern and the potential teratogenicity of pretty much any anti-infective agent used. The other thing that's important is to manage fever appropriately. And we know that sustained temperature of over 39 degrees for over 24 to 48 hours can result in certain adverse outcomes. There's been a few studies saying, well, maybe it's not quite as bad as we thought it was, but the critical period seems to be the first trimester for fever. A study from over 20 years ago suggested that almost 6% of women who had a high fever during the critical period for neural tube closure had a baby with anencephaly, compared to none in the low fever or control group. So really outlining the importance of managing fever, and there have been specific patterns of minor defects identified, including cleft, small chin, so micrognathia, mid-face hypoplasia, and ear malformations. So paracetamol has a long track record of use. It does cross the placenta, doesn't appear to significantly increase risk of birth defects or other adverse pregnancy outcomes. There's been some quite conflicting and controversial data around the increased risks of ADHD and behavioural disorders, as well as possibly genital disorders, but generally in offspring exposed over a more prolonged period of time, so up to 4 weeks. The dose shouldn't exceed the recommended normal dose of 2 tablets of 1,000 milligrams every 4 to 6 hours. Should be used for the not for a prolonged period of time, and it's considered to be safe at all stages of pregnancy and breastfeeding. As I mentioned previously, non-steroidals, there are different risks at different stages of pregnancy. Women trying to get pregnant are discouraged from using non-steroidals because of risks that could affect fertility. And there's a condition called luteinized unruptured follicle syndrome, or LUF. In the first trimester, there's not an evidence about increased risks of birth defects, but there is some evidence around increasing risks of miscarriage, which is paradoxical when aspirin, which is essentially a non-steroidal anti-inflammatory drug, is given to women with recurrent miscarriage. In the second trimester, there is increasing evidence about possibly affecting fetal kidneys and urine output. And the latest recommendations are now saying to avoid use after 20 weeks. At MotherSafe, till recently, until these guidelines came around, we were telling people up to 32 weeks was probably okay. If someone inadvertently uses a non-steroidal, we would be reassuring, but we certainly wouldn't be encouraging them to keep using it chronically. And in the third trimester, there are concerns around premature closure of the fetal ductus arteriosus, as well as fetal kidney damage, which may be irreversible, and also bleeding problems. So next slide. So in terms of preventing infections, it's ideally, again, in planning pregnancy. So women should have an appropriate immunity to varicella and rubella. Inadvertent vaccination with a live vaccine is not a reason to terminate an otherwise wanted pregnancy, but we do recommend waiting the month. The other thing with the varicella is, again, just to be aware or to remind everybody that if someone's had a varicella vaccine, that they may not have seroconversion. It doesn't mean they're not immune, but their testing might not actually reveal antibodies, and don't keep vaccinating people. Generally, most vaccines are going to be considered to be safe during pregnancy and breastfeeding. And again, it's always going to be weighing up risk benefit about vaccine versus theoretical risks of vaccine. I would also strongly recommend that you talk to patients about having a COVID vaccine if they're in the stages of planning pregnancy. It's the ideal time to do it. The COVID vaccine information from that's put out by the government has been a little bit, I think, not as strong as it could have been in its recommendation. It's saying women can have it. I think women should be encouraged, and they're actually looking at kind of beefing up that recommendation at this time. And I suppose this was an old slide in the sense of talking about travel. It's not really an issue at the moment. So, but thinking about if you're going to be traveling to weird and wonderful places in the future, do you really need to go there? So the obvious things around hand hygiene, and then high risk groups. And again, although we don't necessarily recommend screening during pregnancy, but for women, so particularly childcare workers and healthcare professionals, for things like knowing about their CMV status. And again, women taking immunomodulators like biological agents, having their vaccinations before they start on those if possible, particularly live vaccines. So about a quarter of pregnant women are going to use an antibiotic at some time in their pregnancy, 15% in the first trimester. Despite their frequency of use, there's relatively little in the literature to support prescribing in pregnancy. That's because women are excluded from drug trials, so we don't actually know about pharmacokinetic data, but it's likely that the dose should be actually bigger than in non-pregnant women, particularly later in pregnancy, because of pharmacokinetic changes. Older drugs like the penicillins have evidence and safety data from years of accumulated clinical experience, but relatively little formal scientific evidence. Penicillins and the related cephalosporins remain the most frequently prescribed antibacterials, and there's really no evidence about increased risks of birth defects or other adverse outcomes. But really, pretty much very few antibiotics are truly contraindicated in pregnancy. So erythromycin and the macrolides, they're frequently prescribed, particularly women who've got a penicillin allergy. They're relatively reassuring data, although some studies have suggested increased risks of heart defects. The newer Macrolides, there's limited but reassuring data, and again, a prospective study did not show a significantly increased risk of birth defects. But women who'd been exposed to macrolides were more likely to terminate a pregnancy electively, and that, I suppose, highlights, you know, giving people appropriate information. Tetracyclines, there's old data, most of the concerns around staining of teeth, and as I mentioned in the earlier slide around timing, that's not really an issue till 15 weeks. It appeared to be more of a concern with the older agents than with the newer ones like doxycycline and minocycline, and they're the ones that I suppose we see the most, either in people who are travelling and using doxy for malaria prophylaxis and minocycline as well for acne prevention or treatment. Because of the class effect, these associations around teeth staining were applied to doxycycline when it was first developed by Pfizer in the 60s, and that still continues. But in fact, there's quite a bit of information about that it's underutilised in pregnancy because of its concerns, but it's actually an effective, cheap, broad-spectrum antibiotic. There's actually no evidence in the literature of human teratogenicity. And the current doses are about 10-fold lower than the equivalent tetracyclines that we used 50 years ago. So again, I think this is a good example of misperception of risks and unnecessary concerns. And in the US, they've stopped doing the categories, and hopefully that will, I suppose, inform more sort of informed prescribing, but also possibly reassuring people, particularly when treating infections where doxycycline might be the antibiotic of choice, that might actually be risk benefit. Really, there does not appear to be any significant concerns about its use in pregnancy, but it is beneficial. So quinolones, so the sort of ciprofloxacin group, there've been some controversy. There were some early reports about affecting the cartilage of developing fetuses in mice. And so that was always a concern in terms of human, but that's actually not been sort of borne out in the human data. Not a particular pattern seen in birth defects in humans. So so really there's sort of a bit of caution around it, but if it's the best drug to treat a particular infection, we would be reassuring. And again, the overall risk is low. So probably not first line unless it's the most appropriate antibiotic for a significant systemic infection. So Cotramoxazole or Bactrim, again, it's been around for a long time. A bit of controversy around it. There were concerns about increased risks of birth defects, and that was thought to be the trimethoprim rather than the sulfur methoxazole component. It's recommended that if women are using it long term, so for example, preventing urinary tract infections, that women take high dose folate when they're trying to get pregnant. But we, again, wouldn't be discouraging women if it's the only treatment that's useful. Fluconazole is really an interesting drug. It's one of the ones, again, that I mentioned around dose response. It's commonly used as a single dose, oral dose, but it's increasingly being used in sort of lower dose chronic therapy to treat persistent vaginal thrush. Some studies suggested a higher risk of miscarriage. There have been several studies showing no increase in single stat doses of fluconazole in terms of birth defects or other adverse outcomes. And a fairly large meta-analysis did not show an increased risk of birth defects overall, but possibly a slightly higher rate of heart defects. So again, probably not first line treatment, but if it's the only thing that's going to work, we would be not discouraging, particularly after the first trimester. And then there were babies who, over 20 years ago, there was a series of babies who were reported with severe multiple congenital anomalies, but with mothers using very high doses, so between 400 and 800 milligrams a day of systemic fluconazole to treat serious fungal systemic infections. And it looked like a genetic condition called Antley-Bixler syndrome, which is due to a decreased CYP51, which is similar to the effect of the fluconazole on fungi. So it was kind of an interesting thing of where a drug was mimicking a genetic disorder, and it kind of made sense. So high dose, very different to a single stat dose. So in summary, there appears to be a dose-related teratogenicity. The absolute risk is not particularly high, probably even with high dose. There's no evidence of significant teratogenicity with low dose. but there's really little or no data on the outcome following intermediate doses, so that's sort of 50 milligrams a week for a few weeks or prolonged low dose. It's got a long half-life, so it may accumulate in the tissues, and there's no guidelines on how long women should wait before they try pregnancy, particularly if they've had high dose. So as I said before, it's not first-line treatment, but its low dose is reassuring, either if you've got inadvertent use or if you've got failure of repeated doses of other antifungals like clotrimazole to treat thrush. In terms of antivirals, we commonly get calls around treatment for herpes and varicella, really because of undue concerns about even topical antivirals, and that's, I suppose, because of theoretical concerns. There was very reassuring data from quite large Acyclovir registry, which actually stopped because it was so reassuring. Interestingly, there's more data about Acyclovir than for Valacyclovir or Famciclovir. So because the data is reassuring, experts consider Acyclovir to be the drug of choice when indicated in pregnancy, really just because it's tried and true, it's been around longer. But again, just to show you some of the sort of, I suppose, discrepancies or inconsistencies with ADEC, Acyclovir is categorised as B3, Valcyclovir, which is essentially the same drug as B3, but Famciclovir, which is newer and there's much less information, is B1. And I'm not sure if that's because the drug company sweet talked the TGA or whatever, but that it's not particularly logical. And we've had a few disagreements with doctors around that, saying, well, look, we don't, either way, it's probably fine. But, if you're going to ask us where there's more data, we're going to say Acyclovir, and I don't really care what the TGA have called it. So really the take-home messages are really that risks of untreated or undertreated infection are generally significantly greater than potential risks of the vast majority of anti-infective drugs. Limited data means that pregnant women certainly shouldn't underdose for fetal safety, and actually you may need to give bigger doses or more frequently to non-pregnant women. And pregnant women need to be appropriately investigated and treated for infections in pregnancy. So this is the next little segment's just going to be about nausea and vomiting in pregnancy. And I'm not sure if any of you saw this. This was a media release from November last year where New South Wales Health announced that they were going to, that they got $17 million to be invested into treatment of or looking at nausea and vomiting in pregnancy and hyperemesis. So the Ministry of Health are now trying to work out how to approach this and what to do for the state, really, in terms of this. So it's a sort of hot topic and quite relevant. So again, this came out, I and a colleague in Melbourne published a letter to the MJA about 2 months ago about confusion about doxylamine, and then a group from Adelaide published a paper where they basically again said that pregnant women were being denied appropriate treatment for morning sickness. So really just to go through, there's a lot of mixed messaging. The product information and consumer medicine information specifically stating that things like doxylamine, which is really first-line treatment, shouldn't be used, even though it's category A. There are concerns around off-label prescribing and lack of safety. We've at MotherSafe, we've got quite a nice fact sheet that hopefully you've seen, really talking about some initial management, avoiding triggers, eating small frequent meals, appropriate sleep, other things like acupressure, ginger, treating things like reflux if that's an issue, and then thinking about drug treatment. So for those of you who are old enough, there was Debendox, which was a sort of precursor of what is now doxylamine and pyridoxine. Animal studies were negative, but because of concerns about thalidomide and because of some slightly dodgy research, limb reduction defects were thought to be associated. So it was basically removed by the drug company in the States because they were worried about being sued. In the 1990s, a company in Canada started making it again, and it's called dicleptin, and it's now called Diclegis in America. And it was only authorized by the FDA in, I think, 2014, having come out in Canada in 1997, and where it was specifically marketed to treat nausea and vomiting in pregnancy. So because it's not available here, we tell people to do it yourself. So you buy doxylamine. If you buy rest of it, it's a scored tablet, cut it in half. It is category A, but as I said, a lot of our patients say that won't get dispensed. The thing that's harder now is to try and find a 25 milligram pyridoxine or smaller doses of pyridoxine. Up to 200 milligrams a day of pyridoxine is safe. And we tell people who've had a previous pregnancy with severe morning sickness to start using this essentially preemptively, like the minute they pee on a stick in a positive pregnancy test. So the therapeutic guidelines in New South Wales, it's trialling non-drug therapies for a week, then starting the pyridoxine and the doxylamine. So that's first-line treatment, but a lot of patients will not be put on that because it's not live. I can't survey people, but I still think a lot of people are still being put on Maxolon as first-line treatment. Maxolon can be added, and ondansetron, we're seeing a lot of people being put on ondansetron first line as well. And so it's an additive process, and the therapeutic guidelines sort of outlines that. And there was also a very good paper guidelines that came out from SOMANS about 2 years ago, again, talking about the management of MVP. So I'm always a bit puzzled by why everyone thinks metoclopramide's great and they're more comfortable prescribing it. It is category A. And I suppose on the prescribing information, it doesn't actually specifically warn against use in pregnancy, unlike doxylamine, but it does state that adequate human data on use during pregnancy is not available, which is not entirely true. And it's also not particularly consistent with category A. There have been several studies that do show it's efficacious. It's more effective than placebo, but it's not necessarily superior to doxylamine and B6. It significantly increases risks of depression and depressive symptoms, especially in women who've got a pre-existing depressive illness. And there are risks of tardive dyskinesia, but somehow people don't seem to be that worried about this or warn patients. Up to 20%, it's thought that up to 20% risk of tardive dyskinesia with use over 3 months. And even though the prescribing says only use it for 5 days, most women are not going to be on it for 5 days. There was just that link at the bottom. There was an article about a woman who was pregnant and developed tardive dyskinesia and some of the other symptoms. And it's actually really worth reading. It's a very sort of powerful description of how metoclopramide's not quite as benign as everybody thinks it is. Ondansetron, again, a lot of people seem to, it is effective. Again, it's off-label use. There was some data about clefting that didn't really, but one big study didn't really support that. It does not appear to be a major human teratogen. It does cause significant constipation. And so the recommendation is really, it shouldn't be first-line treatment under any circumstances. And the risks of birth defects are going to be limited or minimised if you use it after 9 weeks, when essentially beyond the embryonic period. And so just really, so that's just just to quickly go on to depression and anxiety, just as another sort of common thing. And also, I suppose, again, with the nausea and vomiting, and that's something that will be addressed in the hyperemesis, is just the psychosocial impacts of that. And we know that just in general, depression and anxiety are common. Up to 20% of women will be affected in their reproductive years. Relapse is common in pregnancy, and it's not just postpartum. And I think a lot of patients have this idea that, you know, pregnancy is somehow protected, and it's really just people know about postpartum depression, but the risks of untreated illness are high, and particularly in women with a significant pre-existing anxiety or depression or mood disorder. There's really no convincing evidence of increased risk of birth defects for any of the antidepressants. Interestingly, there's probably more reassuring information about first trimester exposure in terms of things like birth defects versus third trimester, when there are potentially concerns around neonatal adaptation issues. It's important that if people stop medication, that it's monitored and that they're not just sent off on their own with no support. And really important to emphasise a holistic approach. So that's sleep health, seeing, you know, yourselves, the GP, psychologist, counsellor, psychotherapist, perinatal mental health team, and then, you know, whatever other measures are useful. There's just a few basic things. There's no evidence that one particular SSRI is better or safer than the other, and I think that's really important. So there's no point switching from escitalopram to sertraline because people think it's safer. They're basically, you use the one which works the best for people. And we've seen a number of people that have really struggled being put onto Zoloft because there's a belief it's safer. There's really no evidence of that, but certainly use the one that works the best. Some of the non-SSRIs, there's increasing reassuring information, things like mirtazapine, venlafaxine, duloxetine. So yeah, use the one that works the best. And ideally, if there's a positive response, you know, in the past, then that's really helpful rather than just putting someone on a medication they've never tried before. And again, don't use ADEC as a guide. So B3 is not safer than C. So things like, I think, mirtazapine is B3 and most of the SSRIs are C. It doesn't mean the B3 is safer. Often there is information, so check with MotherSafe if you're worried if there's not much information about it and you're worried about the categories. As again, there's no evidence of a dose response in normal therapeutic doses with regard to either teratogenicity or neonatal effects. So generally a drug dose is going to be lower as a pregnancy goes on due to pharmacokinetic changes. So you shouldn't routinely lower a drug dose, particularly later in pregnancy, because that's peripartum periods generally when a woman's most vulnerable and they're likely to need their medication. If insomnia is a particular problem, consider using a sedating antidepressant such as mirtazapine or tethipin rather than adding another agent such as quetiapine or benzodiazepines. Because we know that additive effects, so the cocktail, so the more medications, more of an issue of the adaptation problems. Women who are well should consider stopping an antidepressant before the 3rd trimester, but if they've required it till then, they're probably not going to be cured by the 3rd trimester. So the 3rd trimester, we talk about adaptation problems. It's not entirely clear whether they're a prolonged effect of the medicine or withdrawal. Either way, we say, look, they're not a deal breaker. They're not a reason not to take the medicine, but people need to be warned that they could be an issue and therefore they shouldn't have a home delivery or go home. I generally say till their milks come in and they're sort of settled and feeding the baby. They're transient. They can involve things like feeding problems, jitteriness, some respiratory distress. There's going to be a small percentage requiring special care nursery for observation, but really important, self-limiting and transient. And there's no evidence to say that they've got any long-term effects. Drugs, if you stop a medication, then realizing that it's going to take a while to get an effect. So don't, you know, be cautious about stopping medications just to try and avoid these adaptation problems. Reducing the dose is pointless. And as I said, but taking more than polypharmacy certainly is a risk. And we know that sleep deprivation exacerbates mood disorders. So it's something we always talk to women about is planning once they've had their baby, how are they going to manage the sleep at night to see how they're going to go. Either getting a partner or someone to either, because I always say having 6 hours unbroken sleep is very different to having 2 hours sleep, wake up, feed baby, settle baby, then you try and go back to sleep and then 2 hours later happening again. And that's probably one of the biggest risk factors for depression and women not doing well postpartum. In terms of breastfeeding, if you're going to start an antidepressant in the 3rd trimester, consider drugs that are better options, so like sertraline, but you don't need to, but don't switch just for that. And even fluoxetine, which is one of the higher amounts of drug in breast milk, is still considered compatible. So don't change on that basis alone. If the mother's taken it throughout pregnancy, the baby's going to get a much lower dose than if when they're during breastfeeding than during the pregnancy. If it's a sedating drug or if a mother's on polypharmacy, always observe baby to make sure it's feeding okay and waking for feeds. And as I said, I mentioned really about the sleep deprivation issue. Bipolar, really high risk of relapse without medication. Generally, they're category D, but not all the same risk. Valproate shouldn't be used to treat bipolar in pregnancy because of the high risks. Lithium, slightly increased risks of cardiac defects, possibly 1 to 2%, but a New England Journal paper suggested doses less than 900 milligrams were not associated with a significantly increased risk. Dose needs to be adjusted during pregnancy, and kidney and thyroid function need to be monitored. Lamotrigine, there's no increased risk of birth defects overall, possibly slightly higher risk of clefting with doses greater than 300 milligrams per day. And we recommend taking folate when women are trying to conceive and for the first trimester. And reassuringly with lamotrigine and also with lithium, quite reassuring longer-term neurodevelopmental data. So just in the last few minutes, I'm just going to quickly talk about sort of counselling, pros and cons, weighing up treatment, not treating, risks, benefits, and remembering you've got 2 or sometimes even 3 patients. We always, when you make a risk assessment, you always have to relate it to the underlying disease and the baseline risk. Some people don't understand numbers very well, and so it's, you know, some people prefer odds, some people prefer fractions. But really remembering very few drugs actually significantly increase the risk of birth defects. And if they do, they're going to be much less than, you know, genetic conditions like a 1 in 4 or a 1 in 2. Just to clarify the relative risk. So even if you're taking prednisone, you've got a relative risk of 3 of having a baby with a cleft lip or palate. So her risk is 3 times higher than her neighbour if she's not taking it. The background risk for having a baby with a cleft in the general population is around 1 in 1,000. So 3 times 1 in 1,000 is still only 3 per 1,000 or 0.3%. So the absolute risk is still very small. So just be aware of that. Non-directive counselling needs to be non-directive, and it needs to be individualised. So when was it? So again, that all or none period, no increased risk, 2 to 4 weeks before, after the period, 4 to 10 weeks embryonic period, potentially increased risk of birth defects, and then the fetal period, potential neurodevelopmental sequelae, but not structural defects. The dose, so if someone's using a topical, it's less likely to be absorbed and therefore less of an issue than a oral or intravenous. And make sure you're giving people up-to-date information. So that's not MIMS, it's either textbooks, databases, MotherSafe or PubMed. And again, ideally preconception. So we want to be seeing people on the best medicines before they conceive. Again, just things that can't be unheard. Because of your exposure, your baby will be born with anything. Nothing's 100%. The sort of horrible condescending, if you were my wife, I wouldn't let you take this, or I would want you to terminate. And the other thing that the amniocentesis, really there's no indication from any exposure that you need an invasive test. Many women counselled at MotherSafe have reported these or similar phrases being told to them by their doctor or their pharmacist after often trivial exposures like a single chest or dental x-ray, rubella vaccine. So really just be very mindful. And again, body language can replace many words. So if you don't know, just say you don't know. It's much easier. It's much easier to then give people proper information. It's very hard to unhear what people have been told. And again, you know, don't mention termination or refer them unless you've gotten appropriate information, because again, it's very hard to go back from that. So just really in terms of counselling, not just about medications, but we talk about everything. We have set up a plan clinic, which is short for pre-pregnancy lifestyle and nutrition. And we have a one-to-one with a midwife who goes through all these things. Medications is just one of them. We're happy to see these people, but again, we're happy to sort of provide people with our sort of template as well to go through that. And recognising that it's lots of things. So it's taking folate, it's immunisation, it's social history, and I suppose now, you know, as a geneticist, I can't help but say genetic carrier screening. So MotherSafe, we're happy to see people with any of these sorts of things. So known teratogens, exposure to long-term medications for chronic conditions, substances of abuse, they're not usually the best attenders, occupational exposures, someone who's planning to terminate because of an exposure, even if it's trivial, we're more than happy to see them to try and reassure them. If the doctor or patient is overly anxious. And we also now have a complex preconception clinic. So for women with several medical conditions and medications that, several medical conditions, so not lots of medications, but lots of medical conditions, we're happy to see them as well. And that's a multidisciplinary clinic we do once a month. These are just some useful websites which you will have access to. And then I'm sure, or hopefully you've all seen our website, the MotherSafe website, where we have information about MotherSafe, and we also have a lot of fact sheets about conditions, both pregnancy and breastfeeding. And I think that's me. So me and Barbie, any questions?
Thank you so much, Deborah. That was just such a comprehensive and fantastic presentation. There's a couple of questions people have been asking. There's a few about the COVID vaccine.
Yep.
Touch on that earlier in the presentation, but yeah, just whether you could expand on your opinion on the COVID vaccine in breastfeeding.
So I think one of the important things is that I'm sure I should have put it up, but there's a really great resource that I actually sort of helped develop. So that's what's great. No, it is good. And it's called the Shared Decision Making Aid. So if you just Google COVID-19 or COVID vaccine, Australian government and pregnancy, and it comes up, and it's a PDF, and it's really nice because it goes through in a fairly systematic way about the sort of questions that people might have. So, I mean, I think the bottom line, and we're getting more information about COVID vaccination in pregnancy from around the world, you know, so in places like the US and in Israel and the UK, where obviously the burden of disease was much higher and people were having vaccines. So basically, I mean, the bottom line is that the information's been reassuring. In Australia, obviously, we're in a different situation where we don't have that burden of illness. As I said, so really people need to make, you know, informed decisions. Interestingly, I had a patient last week who is from the UK. I mean, she's been here for the whole of COVID. Her mother's a nurse in the UK. She was 15 weeks pregnant when I saw her, and she'd gone and gotten herself vaccinated in pregnancy, and she'd had to sign all these things, but she wanted it, and she said, yeah, I'm pregnant, I want it. I've been telling, I also see patients in an IVF setting, and I've been telling them they should have it, you know, while you're planning pregnancy is a perfect time to have it. And they're being discouraged from having it when they call up to make appointments. At some of the clinics, they said, if you're planning pregnancy, you shouldn't have it, which is not particularly, it's certainly not consistent with the guidelines. In the guideline at the moment, it says if you're planning pregnancy, you can have the vaccine. And as I said, I think we're going to try and beef that up to you should be encouraged, or it's recommended, particularly because women planning pregnancy are going to be young. They're going to have the Pfizer. So it's a 3-week window, and then they're done, and then they're vaccinated. And there is evidence from overseas, again, that pregnant women who get COVID don't necessarily do that well. And I've got a colleague in Israel who was telling me that, you know, they had 12 women on a ventilator at one point, pregnant women. So, you know, it's an issue.
We have 2 questions about vitamin B12 injections and whether they're safe for pregnant patients.
Well, I suppose it's just why people are having it. So if they've got deficiency, it should be treated, but not just because they, you know, their naturopaths told them it's a good idea. So yeah, I suppose, you know,
about, yeah, for vitamin B12 deficiency for vegetarian patients.
Yeah, I mean, look, I think, you know, again, if it's been documented, I mean, the other group where I think it's important that folate and B12 are looked at women with inflammatory bowel disease, because they actually may well have malabsorption. So they're the things that are worth checking before pregnancy. So, you know, to treat deficiency is fine, but, you know, as I said, we see a lot of people that are on a lot of stuff they don't need to be on. So it's partly about rationalising their medicines.
There's a question about malaria treatment and prophylaxis.
Right. So again, it's, you know, that I suppose that in my earlier talk was about, well, do you really need to go where you need to go? You know, why are you going? But again, malaria in pregnancy can be a life-threatening condition. So again, it's risk-benefit. Chloroquine-based treatments are safe, but again, it's knowing what particular sensitivities there are to the malaria in that particular area, and going from there. And again, things obviously using preventive measures, so the insect repellents and mosquito nets and the long clothing and all that sort of stuff.
There's a question, a comment that says overall risk of topical exposure seems to be low. Does this apply also to prolonged use of topical retinoids in young women?
Yeah, so we get a lot of questions about that. So I suppose, again, it's that if someone has inadvertently used a topical retinoid and then discovers they're pregnant, we would be reassuring, but we would tell them not to keep using it. And the other issue is it's obviously dose is determined by obviously how much you put on it, and also, and the area of skin involved. There was one case, actually, it was in Australia. It was when I was a paediatric registrar, before I was even interested in drugs in pregnancy. And there was a baby that was born with anomalies, and it was thought that that was because the mother had used topical retinoids. It's actually been, written up in the literature. When I was in Canada working at they actually got male volunteers to sort of swallow essentially tubes of topical retinoids, and you need to swallow a lot to have a high dose. So yes, the simple answer is, and the amounts of topical retinoids in most cosmetics are a lot less than from things like Stevia or Retin-A. So it's all about dosage, but generally we'd be reassuring with inadvertent exposure, but we would be recommending people don't continue to use topical retinoids once they're pregnant. And we're actually going to publish a paper on our experience with retinoids shortly, hopefully. And as I said, it's quite sobering because we're still seeing a lot of women who have had inadvertent exposure to retinoid, to isotretinoin in pregnancy. And let me tell you, that's because of deficiencies of the dermatologists, who are the only people who can prescribe, because they don't know about or understand contraception. And that's a problem. So yeah, that's another little rant for this evening from me.
There's another question about vitamin D injections during pregnancy.
Yeah, so again, look, it's all around what, if there's deficiency, then it needs to be treated. There's interesting data now around, does vitamin D prevent other sort of adverse pregnancy outcomes, big doses. And again, I think it's just, and there's also, there's now, there's been some controversy around routine vitamin D testing as well. So some people say you should do it, other people don't. So again, there's a little bit of, there's certainly not necessarily consistency around that either.
And this question around the safety of giving an iron infusion if a pregnant woman can't tolerate oral iron supplements.
Yeah, so again, there's been a little bit of pushback from, so basically iron injections don't seem to be teratogenic. I think that I was involved at the TGA level when they were authorising some of these iron infusions, and I think the recommendation was not before 15 or 16 weeks. It's interesting because a lot of women obviously don't tolerate iron, oral iron particularly well in the first trimester. So, and a lot of the multivitamins that are recommended do contain quite a bit of iron. So I generally tell women not to take oral iron if they've got bad morning sickness, to stop it, and just to use folate and iodine, and then afterwards see how they go. But it's not unsafe. It's again, there's the same issues around, making sure it's given safely, and the issues around, allergic reactions and all those sorts of things. But it's not teratogenic per se. And for a lot of women, it's a better option to have an iron infusion than to struggle with oral iron, which they don't tolerate.